All right, I'm going to go ahead and get started. People can feel free to trickle in as we go, but I want to make sure we have enough time. Can everybody hear me okay? Marvelous. If you can't at any point, let me know. My name's Caitlin. I'm one of the social workers at the University of Cincinnati Center of Excellence for Huntington's disease. I have worked there officially for 2 years. 1 year before that, I was a student, so it was slave labor for a year. But I have been involved with HG since I started there with those 3 years. My background and why I really want to talk to you all about trauma-informed care is I worked in the child welfare system for 5 years, and that was where I got a lot of my understanding of what trauma-informed care is and why it's so necessary, not just in the mental health world and in schools, but in our medical systems and in the care that we provide to our Huntington's disease patients. So I want this to be pretty interactive. I will definitely pause and you guys can ask questions at any point, but feel free, like if I'm in the middle of saying something, like ask a question, totally fine with that. Yeah, any questions before we get started? I have nothing to disclose, I'm not that cool, but you can ask questions on the app. I probably won't check it, I'm just being honest. So if you want to ask a question, just raise your hand and ask it, because I'm just probably not going to look at that. A little bit about me. I love hiking. I have a wonderful dog. His name is Sheldon Cooper. And my mom just got back. We went on a hiking trip to Mohican, which is here in Ohio, which is pretty cool. But yeah, I love adventure and I love adding quality of life to my life as many ways as possible. And something that we try to encourage our patients to do as well. But a little bit about the fun side of me. So today we're going to talk a lot about trauma, which can be a hard topic. So I want to give the disclaimer now that if at any point you feel like it's a little bit much for you or you might have traumatic experiences that are triggered, that's okay. Feel free to get up, walk out if you need to, take a lap, come back with a snack, totally fine. If you need to like stand up at any point because you have like nervous energy, totally fine too. As a social worker, trauma is just like something that is a second nature to talk about, but that's not true for everybody. So feel free to take whatever time you need or whatever space you need. So we're going to talk about ACEs, and we'll get into what ACEs are, but those are adverse childhood experiences. We're going to understand how trauma impacts healthcare, especially with our Huntington's disease patients. Understanding the impacts of trauma, building a framework for trauma-informed care with our Huntington's disease patients, and increasing skills to respond to trauma and prevent future traumas. So the first thing, the foundation of trauma-informed care is that we are all a patchwork of our experiences. Everything that you have done, every person you've met, every experience that you've had makes you who you are, right? And so that looks different for everybody. Everybody has a different quilt or a different patchwork. And trauma can play a big part in that patchwork as well. When there's trauma involved in somebody's life, it can alter the patches that come afterwards. It can impact how we respond to different events and circumstances in our life. And so all of these things combined is what we want to look at as the foundation of trauma-informed care. A person is not just their disease. A person is everything that has led them to the point where you're seeing them in your office that day. And sometimes life happens right before they come to your office, right? There's something that has happened that's part of that patchwork that might have been very recently traumatic. And all these things are just things we want to keep in mind as the foundation of trauma-informed care. So, adverse childhood experiences are kind of, again, that part of that foundation of trauma-informed care. Has anybody heard of or know about the study from 1995 with Kaiser and the CDC about adverse childhood experiences? Has anybody? Raise your hand. I see heads. Good, cool. So that is a really foundational study. If you've never heard of it, I'm going to tell you a little bit about it, but I encourage you to look into it because it's very cool. What they did was they really researched how experiences that someone has as a child impacts their health care, their access to health care, health conditions as they age. And what they found was really interesting, that there's a lot of adverse childhood experiences. Sorry, that got really loud. There's a lot of adverse childhood experiences that, I'm so sorry. We got it, we're good. That really impact the course of someone's life, their access to care, and comorbidities overall. So they isolated several, there's 7 here. I'm gonna show you a kind of a screener that has more, that has 10. So as we kind of go through this, I want you to keep this in mind for our patient population and things that they might have experienced that are adverse childhood experiences. So there's a questionnaire, and there's several different questionnaires out there. I chose this one because I liked the wording of it. And I think I fixed all the typos. There was like 3 earlier, but if I come across one, just bear with me. So I'm gonna read them, and I want you guys to, you can close your eyes or not, whatever, but think about a patient that you have worked with, that you have had pretty close contact with, that you might know a little bit about their life. And think through how many of these might apply to them. And then kind of keep that in your head as we go on. But I want you to keep like an actual number. So if you want to hold it on your fingers, write it down, just keep it in your brain, whatever. But thinking through that for a patient. So the first one, did you feel that you didn't have enough to eat, had to wear dirty clothes, or had no one to protect or take care of you? Did you lose a parent through divorce, abandonment, death, or another reason? Did you live with anyone who was depressed, mentally ill, or ever attempted suicide? Did you live with anyone who had a problem with drinking or using drugs, including prescription drugs? Did your parents or adults in the home ever hit, punch, beat, or threaten to harm each other? Did you live with anyone who went to jail or prison? Did a parent or adult in the home ever swear at you, insult you, or put you down? Did you feel that no one in your family loves you or thought you were special? Did a parent or adult in the home ever hit, kick, beat, or physically hurt you in any way? Did you experience unwanted sexual contact? So those are 10 things which are hard to kind of hear and process, but those are the 10 kind of screener items that we're looking at for an adverse childhood experience. And as you're thinking of maybe that patient in your head, or that person that has experienced Huntington's disease in their life, some of these might apply. I can think of a few of them that would apply to a lot of my patients without even having to know of a specific one. So what we know about ACEs is that they are very significantly correlated to poor health outcomes. High blood pressure, cardiac issues, all these different things that you see up here. Chronic lack of overall wellness, mistrust of medical professionals, mental health diagnoses and suicidality, as well as health risk behaviors such as binge drinking, illicit substance use, all of those things. So when we are looking at a patient as a clinical picture, when we're looking at the framework of who this person is, these things might be pretty significant comorbidities that are existing alongside of the Huntington's disease, partially because of their trauma exposure. So this, I think the statistics speak for themselves with this one, but if you knew that 60% of the people that walked through your door every day had the same or similar symptom, how would you approach every single person that walked into your office? If 60% of the people in the US have experienced an adverse childhood experience by the age of 18. That's a lot of people. 17% of them have experienced 4 or more, which when you look at the research, the 4 is kind of the threshold where you start seeing pretty significant trauma symptoms and trauma correlations and comorbidities. 17%. And the higher that person's ACE score is, the more trauma effects that you're typically seeing. Now that could be 2, it might not be diverse traumas, but it could be one trauma more than once. If you had been abused by multiple caregivers over your lifetime, if you had experienced sexual assault by multiple people over your lifetime, that can kind of be part of that 4 as well. What I would pose is that our HD population, that percentage of 4 or more is much higher, just based on what we know about the generational trauma involved with Huntington's disease. So people with 4 or more adverse childhood experiences have a lot greater risk for developing significant health problems And I don't know if I have a little pointer thing. Do I have a pointer thing on this? Oh my gosh, okay. So diabetes, heart disease, all of these things. And 1.4%, 3.2%, 10 times more likely. 37.5 times more likely to attempt suicide. People who have experienced 4 or more ACEs. That's a lot. And if that doesn't ring bells for us, that's a problem. That's something that is significant in terms of how we treat our patients and warning signs that we're looking for, right? So when we're looking at Huntington's disease, there's a lot that's involved that's in the realm of those ACEs, but specific to Huntington's disease, you have cognitive and psychiatric deterioration of a parent. That's significant. When we looked at the list, right, one of the things on the list of ACEs was growing up with a parent who had mental illness. Definitely counts. And I think with our Huntington's disease population, it's not just depression or anxiety, although it can be. Sometimes there's more significant mental illness like psychosis, hallucinations, delusions, all of these kinds of things that can create trauma for the people living with in that home. Role changes in parentification of a child. Sometimes children have to take on the roles of parents in caring for their parent or in caring for the other children in the home. Impact of at-risk status, that's a huge one in our Huntington's disease population. If you grew up watching a parent have significant mental health, cognitive decline, physical health decline, and knowing that that could be a possibility for your future, that in and of itself is a trauma. That's something that impacts the way that you perceive the world and the way that you structure that tapestry of your life. Non-affected parent-caregiver stress is a huge one. Maybe the person with Huntington's disease has all these problems. The non-affected caregiver is then having to manage that as well as care for any children in the home, manage finances, work, do all of these things, and that stress trickles down to the rest of the family. Attachment issues, which we'll talk about in a little bit, death in the family, and social isolation, which we'll talk about a little bit more later as well. Anybody have questions thus far? No? Okay. There's a really, really good study, which I would encourage you guys to read. It is a qualitative study. They studied 10 teenagers, adolescents, who had a parent affected by Huntington's disease. And the reason I say read it is because they have direct quotes from those adolescents, and it is sobering, I would say, but very interesting in regards to how people view what their experience is with their affected parent. There was themes that they kind of developed from that study, one of which is an increased exposure to anger and violence and aggression in the home. Higher and more frequent grief, loss, resentment, and anger. Typically, people who grow up in an HD family have an earlier exposure to death, have an earlier exposure to that loss of function of their parent, the loss of all of the ways that life could have been with that family. The role changes, again, with the child who's affected. Interrupted adolescence. If you know anything about the stages of development, when teenagers are growing into adulthood, that's their identity formation stage. And when you have the effects of Huntington's disease, that can be impacted because there is those role changes. They're having to take on more of a parent role. They might be socially isolated from their peers. Sometimes, because of the secrecy and vulnerability, nobody even knows that this is what's happening. They might be labeled or blamed as, the quiet kid in class who doesn't talk to anybody, but really they're trying to figure out how they can pick up their siblings after school and make sure that their little brother gets to violin lessons later. So there's this interrupted progression of identity formation, which can then impact that person for the rest of their life in healthcare, but also in educational attainment, job satisfaction, and job stability. All sorts of aspects of their life, their willingness and ability to attach to other people in the community, to attach to a partner. It impacts a lot. Living with genetic results, that's, again, we talked about that a little bit, but fearing for other families at risk, regardless of what your genetic testing results are, how does that impact everybody else in your family? When you have something so generational, it's hard not to consider everybody else in the decisions that you're making, right? And that can really impact the trajectory of life. And then the loss of a parent. And even if they're alive, I think that's an important piece of it, because the parent who is affected by HD may not be the parent that that person thought they would have at the time, right? Or their co-parent. Sometimes when one parent is affected and the co-parent takes on fulfilling all of those roles and they have role shifts and role changes, it impacts the functionality of the rest of the home. And some people essentially lose two parents because it's so different. That person is full-time caregiver for the one parent, and then they're really kind of left to figure out how to fulfill that identity formation, how to go to school, how to do normal things, which feels not so normal. There was another study about genetic diseases in general. Most of it was about genetic breast cancer, but there was also some information on HD with this study. And a lot of similar themes impacting attachment, how children might attach to a family member who has the experience of having Huntington's disease or has the experience of having a genetic condition. If there is that interrupted family dynamic, there may be intentional or unintentional, typically unintentional, neglect of that child and what their needs might be. This is not every family. A lot of the wonderful thing about Huntington's disease is that so many people village around people with Huntington's disease. So those roles are not always filled by a direct parent, but can be filled by other people. But there is still the risk of sometimes children experience neglect because of this shift in family dynamics and the shift in roles. Anxious or insecure attachment can occur with that sometimes, which is anybody familiar with like attachment styles and what that looks like? A little bit. Okay. There's a lot of research about attachment, especially in the child welfare world, because it can be disrupted, right? So what we know is that there's a serve-receive with a parent when you are developing attachment, right? So the child serves, hey, I need something. The parent receives the message and then serves back, okay, let me meet your need. And there's this constant serve-receive back and forth, which builds trust and builds that attachment. Sometimes in an HD family, that's interrupted because the child serves, hey, I have a need. The parent says, I see your need. I'm busy dealing with these 8,000 things over here to manage this person with Huntington's disease. Or it's the person with Huntington's disease themselves maybe not being able to cognitively return that need or functionally return that need. And then there can be some dissonance with that. And then let's see, mistrust of medical providers. We're going to get into that one a lot because I think that's a really important piece in the Huntington's population and with trauma in general. Patients may be less likely to seek support and have increased susceptibility to stress. Sometimes when working with a genetic disease that spans through families, it kind of becomes this is the norm. This is where we're at. We are constantly underwater. We're constantly struggling, and there's no relief. And that can really impact how someone manages stress. When you're already drowning and somebody says, oh, here's 10 books to hold, and you're like, I can't. If you're swimming, you can't hold books and swim at the same time. It impacts that for people. The stress management, which then, if you've ever had a patient who it just seems like everything, there's like one thing after another, and they can't seem to get their head above water. Sometimes that stress management is impacted with their health care. And then the first thing that kind of falls off when the world's underwater is we're not going to take our medications, we're not going to follow through with recommendations, we're going to stop physical therapy, all these things that we kind of promote for patients. So think about your patient population. What symptoms or factors relating to care might be impacted by childhood trauma? Anybody have a thought. Quiet room, that's fine. It's a heavy subject, it is. I think one of the things that I see most, oh, yes. Yeah, suicidality for sure. When you have all of these stressors, not a lot of supports, that definitely increases it. And then having a history of that trauma can impact that as well. Yeah. Yeah. Absolutely. She said attachment and trust towards medical providers, 100%. And we're definitely going to get into that more because I think that's a huge piece of the care that we provide patients. Yes. Yeah, absolutely. Co-occurring mental health disorders. Sometimes too that happens with people who genetic test, right? If they are pre-symptomatic, they might panic every time they have a mental health disorder like depression or anxiety or things like that. And they're like, oh my gosh, it's HD. But it can be a co-occurring mental health disorder related to trauma, right? So you might be wondering, Caitlin, why are we talking about children? We treat adults. Because it's important through the foundation of a genetic disease, right? Every person is not an island to themselves. Everyone who has Huntington's disease came from a family who also had Huntington's disease. And without recognizing them as a village or a family, we're missing the point. We're missing the greater picture of what this person's life is like. So there are a lot of traumas that can occur after the age of 18, though, that also impact our lives. Medical trauma is a huge one that I see. People have traumatic birth, emergent medicine, if they've been in a car accident and needed emergency surgery, anything like that. Those can be incredibly traumatic. Sexual assault, we know the numbers. They're high. 1 in 4 women are sexually assaulted. 1 in 8 men are sexually assaulted in their lifetime. And that creates, and it could be prior to the age of 18 or after, but all of those things impact the clinical picture of how they might respond to us as providers, especially with medical trauma. You know, one of the things that people often say is the most traumatic part of, let's say you go to the ER and have to be rushed to emergency surgery, that the lights, you know, I don't know if anybody's clinics have fluorescent lights, but those can be very triggering for people who have any kind of medical trauma, especially if they've had something done to them. Sometimes the only thing that they remember from the experience is the lights and the sounds. So the beeping, the lights. Sexual assault, I try to touch them. We can see this a lot, like when we're doing testing for patients, if you're doing like the tapping, the touching, the nose to finger, the take your shoes off kind of a thing. I don't know why I was holding this like a microphone. It really can be traumatic for people if they are not aware of what's going on, because they may have had an experience where someone touched them without their consent. Incarceration, car accidents, socioeconomic difficulties over time. This is one where what we know about trauma is there's big T traumas and there's little t traumas. Big T traumas are kind of these things of like medical trauma, sexual assault, war, relocation. Those are like big T traumas. There's an event that happens that is traumatic, right? Little T traumas are accumulative over time. Socioeconomic difficulties can be one of them. It can mean we didn't have enough money to buy food this month, food insecurity. We didn't have enough money to pay our bills. We didn't have enough money to get dad the wheelchair he needed or the walker that he needed. All of those things can accumulate and cause stress in the mind and the body, which is little T traumas over time. And the big one that I wanted to point out here too is genetic testing. That's a huge trauma. And I know that it's also a good thing, and I want to just emphasize really quick that it can be both. Genetic testing can be positive for planning and also traumatic. It can be necessary for families if they feel that that's something that's necessary in their journey, and also be really, really hard. Whether you're positive or negative, there are impacts to the process. If you're positive, you then have to live with that until you develop symptoms with that knowledge, which is traumatic. If you're negative, you might have to live with the fact that you don't have it, but everybody else in your family does. And then potentially be a caregiver for everyone else in your family, make decisions for their care. It's a lot, regardless of what the answer is or what the result is for that person. So when we look at the person with Huntington's, I want everybody to really quickly close your eyes for just 10 seconds. It won't be long. But think about 3 or 4 things in your life that provide you with a quality of life. So mine is probably my job, my friends, traveling, and hiking. And my dog, yes, Sheldon Cooper. All right, everybody have their couple things? When you think of the person who has Huntington's disease, put yourself in those shoes. If you had Huntington's disease, how many of those quality of life measures for you would be impacted? How many say 1? How many say 4? Yeah, it's huge. There's so much loss with something like Huntington's disease. There's so much loss with the degeneration of the mind, the body, what's going on in the family. And it's a trauma in and of itself to be progressing through the disease, right? There's the physical loss, the cognitive loss, employment. Whether you like your job or not, it provides structure to your life, and it's important to have that structure, and that's a quality of life measure. Major milestones in their family, that could be lost. Maybe I won't see my daughter graduate from college. Maybe I won't see my son play in the World Series. Fingers crossed, right? And that independence, they lose the ability to be independent, to make autonomous decisions, and that is such a major loss for people. So what does this mean for us, right? We've been really depressed for most of this first part of the talk. And what does this mean for how we interact with patients? I think it means everything, truthfully. When we look at trauma and severity of symptoms, we know that trauma can impact the severity of symptoms. People who have a significant history of trauma may experience symptoms at a greater degree than other people. And that's something to keep in mind when we're treating, because 2 people might come in with similar experiences, but their perceived effect of what's happening might be different because of their ability to manage stress, their comorbidities, their family support. All of these things impact their ability to process and work through some of their symptoms. Do we all hear that? Okay, just checking. Re-traumatization can occur as a result of interacting with medical trauma or medical professionals. We talked a little bit about that with the lights, the sound. Some of it can just be the presence of being a medical professional. There is a power dynamic, whether we want to believe it or not. There's a power dynamic when someone in a white coat enters a room. That can be re-triggering for someone who has experienced a trauma. Potentially, how many people, when you tell them you're a doctor or you work at a hospital or whatever, they're like, oh, I hate hospitals because every time I go there, someone dies or something traumatic happens. Has anybody ever heard that? Yeah. It's a real thing. And some of us are like, oh, haha, whatever. But it's a trauma reminder for people. Sometimes just stepping into the building is a trauma reminder for all the successive losses they may have had in their life. And we can inadvertently re-traumatize people because of that. Trauma can impact seeking care and trusting medical professionals. We've touched on it. We're going to touch a little bit more on it. Specifically with Huntington's disease, because it's so dynamic in families, everyone has varying degrees of interactions with medical professionals. Some of them are really good, some of them are really poor. Sometimes people come to us having been to 10 different doctors and nobody knows what's going on with them, and then finally they come here and they're like, oh my goodness, who knew? All those contacts, though, with other people in the medical world impact how they view each of us every time we come into a clinical encounter. Sometimes I think we see this a lot with if somebody has had a medical professional talk to them and give them information, but maybe not give them information in a way that they can understand, and then they feel lied to. Has anybody ever seen that where somebody's like, they told me this, and we're like, we really didn't, but they might not have understood what was going on. that can create that kind of rift of trust with patients and medical professionals. That can hopefully be repaired, and we'll talk a little bit about that. But there's so many pieces that impact the trust between a provider and the patient, and we want to try to protect that as much as possible. There are so many of these historical, generational traumas that impact what that clinical encounter looks like, and we want to be able to provide as much safety and stability as possible to improve that trust. And we'll talk a little bit about that as well. Any questions thus far? No? Okay, y'all are quiet, but that's fine. Mindset shift. We want to change from what is wrong with you to what has happened to you. When we shift, as people in the medical world, we're always looking for what's wrong, what can we fix? This isn't always something that has a magic bullet, right? You can't just magically fix that someone has encountered or experienced trauma. So we want to shift our mindset to what's wrong to what happened. What has happened in your life that has led you to this point, and how can we adjust to help make this clinical encounter better, safer, and more encouraging for you? Again, it's that tapestry of, are we looking at just the symptoms, or are we looking at the person as a whole and everything that they bring to this clinical encounter? This was a really great quote that I saw in an article by Grossman here. But it says, collective trauma is a collective responsibility. It's imperative that we recognize the impact of trauma, unspoken traumas that are brought to the clinical encounter. It's part of who that person is. We can't just ignore that this is what they're bringing with them. We had a patient a while back who had a lot of trauma. He was a veteran. He was in his 60s, had a pretty significant history of sexual abuse, both in the military and by a physician, actually. And one of the things, he had come for an initial visit, was fine, but didn't really say much, just kind of went in, did the thing, left. I got a call a couple of weeks later, and he said, hey, I got your information from the front desk, and I want to talk to you before I come to my next appointment, because all of these things have happened to me. I've had all these traumas, especially sexual trauma, and I feel very uncomfortable in a room with a male provider because of what has happened to me. It's pretty important when that person is A, willing to say that, but B, willing to recognize that that's impacting their care, right? When they came in the first time, they didn't say a word about X, Y, and Z symptoms. They were like, I'm afraid to talk about it. I'm afraid to talk about the fact that I have these movements, or that I have these thoughts, or that I'm depressed because I don't trust this person. So having the knowledge that this is coming in is helpful in how we interact. And we'll talk about ways that we can do that, but shifting our mindset to what has happened to you. It's not that this person is neglecting their care or neglecting to tell us what's going on, but there's real trauma and real fear in imparting that information on someone that they don't trust, right? So when we look at principles of trauma-informed care, we're going to go through these individually, but we want to look at safety, trustworthiness and transparency, peer support, collaboration, empowerment, and humility and responsiveness, and how we build our clinics and our patient encounters and our research encounters to kind of envelop this to create safety for patients and to create a bond and trustworthiness with them. So some of these, I'm going to disclaimer this, some of these are like simple things. And when I've brought it up to people in the past, they're like, Caitlin, this is kind of dumb. And I'm like, it's not. It is simple. I'm not going to say it's like complex things, but it is things that we don't always consider when we're talking with people in a clinical setting. So one of them, keeping noise levels low. Some people who have experienced trauma, noise can be significantly triggering or re-traumatizing to them, especially in a medical setting. If there's like lots of beeping, lots of talking, shouting, laughter, that can be really triggering for someone who has experienced some kind of trauma. And that person who's in your clinic might be having the absolute worst day of their life, right? If they're receiving genetic results, if they are getting a diagnosis that's really hard, it could very well be one of the worst days of their lives. And having that kind of calmness in the clinic to say, we're here to support you, we don't want to overwhelm you, is important. Basic needs. Who has Who has a knowledge of like Maslow's hierarchy of needs? Are we all familiar? Yeah, okay. So like at the base of your pyramid, you have physiological needs, right? Which is food, water, shelter, all those things. Then you have safety, right? Those are the next two. So when we're looking at creating safety, we want to fill in those bottom two parts of Maslow's hierarchy of needs. If there's basic needs, so restrooms, where's the restroom at? Let that person know that they can go to the restroom. If you have water, give them some water. It helps to build that trust because we're meeting basic needs first. We have water in our clinic to give to patients, and I think it's really to pacify people if we're running behind, truly. But it's so helpful in building that trust and building that connection with patients to say, we're going to meet your basic need first, and we're going to kind of work from there to figure out what's going on. We already talked about bathrooms and exits. Be consistent, predictable, and respectful in your responses. People who have experienced trauma don't always see responses in the same way that other people do. The way they perceive facial expressions can be altered. They tend to think that people who have a neutral facial expression have an angry facial expression. And so that's, every time you interact with them, what you think you're giving to a patient might not be what they're receiving from you, from facial expressions or from your voice tone, anything like that. So it's important to be overly aware of those things and to build connection as easily and as directly as possible. If every time they call the clinic, excuse me, I'm gonna get a drink of water really quick. If every time they call the clinic, they're getting different responses, they're getting different people, they're getting, one time somebody responds in 24 hours and the next time it's 2 weeks, it's not building the trust, right? It's not building that safety, that felt safety that they're saying, okay, when I serve my need, you're responding to my need, right? And then narrating what you plan to do. This one is so important. I cannot emphasize this enough. If you are going to touch a patient, if you're going to do any kind of assessment with them, narrate what you're doing. The worst part for patients who have experienced trauma is the not knowing. There is so much anxiety and stress and not knowing what's happening. And if you say, okay, touch their knee, touch their toe, touch their head, they're like, what just happened to me, right? It can be a lot. And talking through it and demonstrating on yourself can be really leveling, as far as leveling the playing field to let them know what's about to happen. Eye level, this one is very important as well. Every time we walk into a clinical encounter in a white coat, if you're standing, they're sitting, there is a power differential every single time. And that power differential can decrease that trust in their provider and decrease their felt safety. If they don't feel safe, they're not going to tell you what's going on. Intonation and voice, being mindful of your voice might not always be perceived as the way that you think it is. Having a calm, slow process is helpful for patients to process not only the information that you're giving, but to determine, is this person a safe person for me to provide information to? So sorry, okay. Stay timely. This one's really hard. I think at least in our clinic, it's hard because we want to spend as much time with patients as possible. We want to give them the best experience. We want to listen to them. We want to hear their concerns. But sometimes for the patient that's waiting an hour, they don't feel heard. They don't feel safe because they might be like, well, I've been sitting here. It must mean that they don't think that I'm worthy of their time, or they don't think that I am important enough for them to be here, which is not the message we ever intend to give. But especially for people who have a history of neglect, where that serve-receive is not constant or continuous, it gives the same effect of ongoing neglect, which can be re-traumatizing. Being aware of physical height and distance, again, your presence alone can be re-traumatizing. So how do we level that? If you're really tall, coming and sitting with a patient instead of standing over them. Physical distance, some people really don't want you to be near them. So don't stand right here, right? Having a separation of a couple of feet. And then asking and waiting, this one is so important as well. I think a lot of times in clinical encounters, we say, okay, I'm going to do this and this and this and this, instead of saying, is it okay if I grab your hand for a minute? And then waiting for them to say, yes, it's okay. Asking and waiting gives that person the autonomy over their body that they might not have in other realms of their life. When you're experiencing deterioration on a physical and cognitive level, you might not always have the choice of what happens to your body, and providing choice, even in those small areas, can help repair some of that relationship and provide that trust in a clinical setting. Also, very important, being aware that patients might not be able to verbalize their distress. They might not feel empowered to verbalize their distress, and giving them somebody that they can contact is really helpful. So when we have patients go in a room, if I go in first, I always try and say, hey, if you need anything at all, the nurse is the first seat in the pod on the left. She's right here. She will help you. She will give you what you need. That way they have a point of contact to have somebody if something comes up or if they're feeling uncomfortable. Any questions before we go? Yeah. 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 Yeah, definitely. You know, when you think of traumas that someone might have experienced, sitting in a room by yourself for a long time can definitely be re-traumatizing. If they've experienced neglect, if they've experienced abuse, if they have experienced abandonment, loss of a parent or caregiver, all of these things can impact the feeling or felt safety around sitting in a room by yourself, which can't always be helped, right? Everybody has a job to do. Everybody's running around doing a lot of things. Providing choice in those moments is critical to say, hey, you're going to be here for a while, letting them know what the plan is, what the next steps are. You're going to see this person, this person, this person, and this person. You might sit here for a minute, but you have the choice. Would you like to sit in this chair or this chair? Would you like to keep the door open or closed? Would you like to have water? Providing choice and giving them autonomy in that space where there's not a lot of choice can help with that empowerment. Yeah, great question. Yeah.
I wanted to, wow, this thing's really on. I wanted to just add to that question. You know, I think as a sponsor, we are unfortunately going to inflict some medical trauma.
Sure.
That's just, I think, the reality of often what we're asking of folks.
Yeah.
And we have tried, I'm with Spark, and we have tried certainly to think pretty deeply around how we might address some of support at the site level, right? Because I'm not in the room to really make sure that some of these very thoughtful pieces of trauma-informed clinical care are happening, but what can we provide? And some of the roadblocks we've hit are certainly around IRBs at your institutions who will say, you can't give them a pad. We can't provide VR headsets. That's an inducement. So I think perhaps there's work we could all be doing at the IRB level to socialize some of how this attempts to address that this isn't a giveaway. They stay at sites, they're for participants to use while they're at site, they come back to site, right? But ways that we might think about working with our institutional review boards to somewhat sensitize them to why we're asking for some of these materials, because I think, you know, I'd welcome other thoughts on ways to mitigate some of this, but these are long days where people are left in, a lot of abandoned situations just by the very nature of how, unfortunately, healthcare works. So,
and that, you know, their basic needs, if they are stuck in there for a long time, they might be hungry, thirsty, need a pad, need anything else that, you know, basic human needs. Yeah, absolutely. That makes a huge impact. And that's a great thought to talk to the IRBs and different things. Anyone else? Thoughts, questions? Okay, cool. Again, feel free, interrupt me whenever. I love that. I love to be interrupted. So trustworthiness and transparency, we've talked about trust a lot, but it's so critical in the clinical setting and in research settings as well. Be honest about diagnosis, treatment, and prognosis. I think in the Huntington's disease world, we do a good job of this. Part of that, I think, is because there's not a cure, and so we can only offer what we can offer. but being honest about that and saying, even with research trials, sometimes we want to provide the hope and say, hey, you might qualify for this trial or you might qualify for this trial, and sometimes they don't, and that's hard, but being honest and truthful and giving them the information that they need is important. We don't want to give false hope. We don't want to lie by omission, and building that trust is critical on them having all of the information possible for them. Again, we're going to inform and what they expect. A lot of times, especially in our genetic testing clinic, a patient is seeing like 4 to 5 people that are coming in the room. The genetic counselor comes in, social work comes in, a fellow comes in, the doctor comes in, the genetic counselor comes back in, they go downstairs, they get a blood draw. It's like a lot of things. But setting that expectation and letting them know this is all the people that are going to come in the room, this is what they're going to do, is really helpful for them to have good expectations of what's going to happen in this visit. Somebody's not just going to come in and stab them and take their blood. Somebody's not just going to come in and say, go over there, do this. You're going to stay here, everyone's going to come to you, but this is all the people that are going to be in the room. And that gives them an opportunity as well, if they have any concerns. Some people feel more comfortable with one person than another, and having different people coming in the room but letting them know gives them the opportunity to say, okay, maybe I will tell this to social work when they come in, or maybe I will tell this to the fellow when they come in if they don't feel comfortable with one person or another. Let's see, narrate again, really, really important. More eye contact, less computer. 2024 is hard. We have a lot of computer things. And there's so many, flow sheets and notes and all these things to fill in, but that sometimes creates distance with our patients, especially, again, if they've experienced some of those childhood traumas where they might have been neglected or abandoned, and they might not feel heard when someone is using their computer the majority of the time. And really, I know it's so hard because we want to get our note done while we're in there, because who wants to do notes? But having the ability to say, okay, we need to pause, we need to build this connection for trustworthiness and transparency with the patient, and then go back to our note. And using speech that matches level of understanding, this is so important. Most of our people don't come with extreme health literacy, right? Most of our patients, most of our families don't have good health literacy. And when they come in and they're getting information in a language that they don't understand, they are much less likely to trust the interventions that we could provide, or to trust that any information that we're getting from them from a research perspective is important, because they don't understand what's going on. Typically, what they recommend is to speak to people on like a 3rd or 4th grade level, which for people who are PhDs can be very hard. But that's important for them to level that playing field again, to diminish those power imbalances and to build trust. There's a lot of populations that experience mistrust of medical providers just because of historical things. When we look at all of these, I'm sure we can think through what has happened historically for people that this may have impacted their trust of medical providers, right? And these can be comorbid with our patients who come from Huntington's disease families, which then creates maybe even a greater lack of trust in our medical providers. Peer support and collaboration. I'm going to skip a lot of the peer support part because we want to encourage our patients to get peer support, but focus a lot on collaboration and us looking at the patient as the expert on their lives and giving the patient, again, that autonomy to create choices and to fulfill those choices for their medical care. So many times, especially with Huntington's disease, choice is stripped away from patients pretty early on sometimes. Sometimes patients who have more significant psychiatric concerns, maybe there's guardianship involved, powers of attorney, maybe they lose more of like swallowing or have those kind of challenges. Those choices can be stripped from people, and building those choices back up to create the ability for them to be the expert and have autonomy in their own life is so important. They might be resistant to things. That's okay. In any choice, if you've ever seen, there's a scale that they use typically for substance abuse when people are considering making a change, like the pre-contemplation. We're not here for that change right now. We're not going to try that medicine. contemplation where I'm like, I'm considering it, not quite there, but considering it, making that choice, following through with that choice. There's like a process. So when we allow the person to be an expert, there might be some resistance when we allow them to have the choice, but there's the potential that also that choice could move based on the information and the trust that they build with clinical providers. And then empowering, again, creating choices. This one, we've talked about creating choice a lot, but even small choices make a big difference. When someone has, when you walk into a room and you give the choice of, do you want to sit in, we call like the exam chair, like the big chair in our office. Do you want to sit in the big chair or do you want to sit in one of the other chairs? Do you want to have the light? We have dimmers too, which is pretty cool. We're very blessed at the Cincinnati. But would you like the lights all the way on? Would you like the lights halfway on? Would you like the lights off? Would you like to do your mocha first or your mocha last? Would you like to walk the hallway first or walk the hallway last? Would you like to do your blood pressure now or your blood pressure later? All of these things, even though they're seemingly small and possibly insignificant to most of us, that might be the first choice that person has had to make all day. The first choice that someone has allowed them to make all day. And that's so critical, creating that choice and empowerment for people, even when there's not a lot of choice, makes a huge difference in how they perceive care and how they perceive what we're able to provide to them. And I'm going to skip that one, even though it has a really cute puppy. We're going to skip it for a second. Humility and responsiveness. This is like, I'm somewhat known for like making weird phrases very popular in my life. And this is one I really like to use, but you are a superhuman, but you are not superhuman. Let it sink in. I know, it's deep. You are a superhuman, but you are not superhuman, right? And this goes for us as people working with patients with HD, as well as caregivers, family members, the patient themselves. You can only do so much, right? And as people who are working with patients with HD, sometimes information changes, right? How often does research change and the information that we have to give to patients might change, or interventions might change, or life changes, right? Being able to say, okay, we recognize that there was a change, admitting that something has changed or that something is different, or maybe, if there is that rift that occurs in trust, saying, we did the wrong thing. Acknowledging that we can make mistakes is the first step to rebuilding that trust and positive connection with a patient. And then also, it's okay to not know, which I think most of us are pretty good with. I think in the research world, we don't know a lot, right? We learn, we figure it out, we develop, we research, but we don't always know, and that's okay to let patients know that. It brings our humanity to the forefront, which then they can match with their own humanity and say, okay, we can be on the same level now. I can talk to you and I can have trust in you because I see that you are also a human. You're not just a robot. How are we on time? Oh, cool. They gave me like a lot longer than I thought. So we might finish a little bit early, but again, feel free. If you have questions, pop them in there. I wanted to talk about secondary trauma with all of us who work with patients with Huntington's disease. Is anybody familiar with the concept of secondary trauma? Yeah, okay. If you're not, welcome. I'd like to introduce you to the topic of secondary trauma. Secondary trauma is, I'll read the definition for you, but it's emotional distress that occurs when someone hears or bears witness to the trauma of others. As people who work with patients with Huntington's, we bear witness to a lot of trauma, a lot. You bear witness to it when someone walks in your office having just had genetic testing. You bear witness to it when someone has had some degeneration and they're no longer the person they used to be. You bear witness to it when family members come in and they say, I don't know what to do anymore. I can't do this. You bear witness to it when over and over in a day you have 10 to 15 patients who are worse off than they were a year or two ago. It's a lot. And as people who work with patients with Huntington's and who experience and bear witness to that trauma, it is imperative that we take care of ourselves and address that secondary trauma in ourselves in order to be able to help our patients. There's like a lot of kind of hype words in the social work world that I'm going to kind of touch on. You may or may not be familiar with them, but compassion fatigue is a big one. Compassion fatigue is when you have basically your body and your brain is unable to intake any more things that require compassion. When you are witnessing traumatic things consistently, when you are witnessing really hard and painful things, there's only so much that a person without doing your own kind of self-work can do. And compassion fatigue comes out in our patient interactions too, when we encounter a patient who has life going on, right? They have a lot of things. They have caregiver issues, they have finance issues, they have housing issues, all these things that we see so much with HD. We become less compassionate. We say, well, hope you figure that out, you know? And that's hard. That's really hard, but it is a part of what we encounter as people working with Huntington's disease. You bear witness to so much, and without caring for yourself, that compassion fatigue can really impact our patient care. Decision fatigue, this one is something that I personally have experienced. When you are in a position to make decisions for another human being constantly, sometimes it's hard to make your own decisions. And this we see a lot with caregivers, and that's something to definitely be aware of from when we're assessing and working with caregivers and family members. But also, as people working with people with HD, sometimes you find yourself in that position when you're not necessarily making decisions, but making recommendations for people, establishing plans of care. It can be hard to make your own decisions. And decision fatigue, the best way I can describe it is when you go to your pantry at the end of the day and you look in there and you're like, what can I eat? And then you stand there for 10 minutes and you decide, I'm gonna eat a bag of chips. And you close the door. And then you have 4 chips and you put the chips back and you're like, just kidding, I'm gonna eat a cookie. And then it's just like the progressive food crawling around your house until you figure out that, oh, I'm full on junk food. Decision fatigue, right? When it's hard to make those decisions because of what we're having to make decisions for in our professional lives. Burnout, we all are aware of this because of COVID, right? Burnout is real. You can't work forever with no break. You have to provide yourself with some self-care. Lack of job satisfaction, depression, anxiety, hypervigilance. I think this one can apply a lot with patients who have psychiatric concerns. If you've ever been in a clinic where somebody is like escalating, or maybe a research patient is like escalating and it gets really scary really fast, you can develop hypervigilance from working with patients like that. People who work in psychiatric arenas, that kind of thing is pretty common. Hypervigilance, hyperarousal of your surroundings. Avoidance, I just don't want to go to work today. Has anybody ever felt like they just don't want to go to work today? Is it just me? Okay, good, okay. Sometimes avoidance is a real thing, right? When you work with patients who have significant trauma, who have family problems, who have, you're pouring out all of this compassion every single day, sometimes avoidance is unavoidable. I just thought of that just now. Sometimes avoidance is unavoidable, and it's hard because you want to go to work and you want to do the things that you can for patients, but dealing with that for one more day can sometimes feel overwhelming. So it's important to take care of yourself, whatever that looks like, grabbing your own support, finding a therapist, a counselor, having debriefing sessions. I have worked with several other compartments in our hospital setting that have debriefing sessions, which everyone says is so helpful. If you have social workers at your team, we're happy to chat with you. We always are. But finding your own support and building that support as a consistent part of your life and as a part of your clinical practice is crucial. Resiliency. This is the good part. People are resilient. Despite having significant traumas in their life, there are factors that increase resiliency and provide for as protective factors against those adverse childhood experiences, adverse adult experiences. And those are your support system, your connection, feeling in control, and planning. All these things that we've kind of talked about as how we build trauma-informed care. How do we help people build support systems? How do we help people connect to their healthcare team? A lot of the ways that we've talked about. How do we make people feel in control of their decisions, even if they're minor ones? Choices, creating choice, right? And advanced planning and autonomy. Having people, this disease is hard. There's a lot of, there's a lot of freedom and, not freedom, there's a lot of, the word is not coming to me, but there's a lot of benefit in having the ability to plan for your care for when you're not able to make those decisions. If you can plan ahead of time and create that autonomy for your future self, it creates less stress, less trauma at the time when those decisions might have to be made. And I have a case study, but I don't think we're going to do it. We're going to skip through it. So the 4 R's, when we're looking at building a trauma-informed organization, we want to say, how does trauma affect people and individuals that we serve? And that can be specific to communities too. If you work in a community that's near a military base or that is more impoverished, you might have a significant higher rate of trauma in your area. How do we recognize the symptoms of trauma in our patients? How do we respond to patients in a trauma-informed way and resist re-traumatization as much as possible to all of our patients? What we see is that people who develop trauma-informed care frameworks have better outcomes. A lot of times, there's concern, this is going to take forever if I give them choices, this is not going to, my clinic is going to run late, all these different things. But what we know is that there's improved emotional health for patients, higher patient retention and fewer patient complaints, higher physician satisfaction, increased compliance with recommendations from patients and family members, improved length of visits. It doesn't take less time, it doesn't take more time, it takes less time. When people feel empowered to tell you what they need to tell you, they don't go all the way around Texas to get to their point, right? When people feel like they have the autonomy and the support to voice their needs directly, it takes less time. Experience less subsequent medical care. If we can get people what they need, if they can voice what they need, feel empowered, we can support families. They require less ER visit trips sometimes. There's less, has anybody ever had a patient who goes to the ER every 5 minutes? Yeah, that can be a trauma response too, because that's the only place they're getting their serve receive met immediately. The only place that they're going where they're saying, help, I have a problem, here's my red flag, and they're saying, let me help you, Sometimes that's the only way that need's getting met. And then greater trust in healthcare providers, which we've talked about building that trust, but that's the key component of a lot of this trauma-informed care process. So, I have some resources if anybody wants to learn more about trauma-informed care or trauma in general. The Body Keeps the Score, excellent book. If you've never read it, I encourage you to do so. It talks about how trauma is stored in the body. The University of California, San Francisco Center to Advance Trauma-Informed Care, the National Child Traumatic Stress Network, and the National Center for PTSD are all really beneficial resources for you in building that trauma-informed care into your clinical practice. And that's all I have. But anybody have any questions? Thank you. Thank you. If you have questions later, I'm around, but feel free to be done early.